So far, we have brought you the story of unsustainable and rising costs of healthcare in America that are resulting in unaffordable care, unaffordable insurance, and a critical decline in access to both. So far, we debated the moral and ethical questions surrounding healthcare and contrasted public policy and free market approaches to the provision of healthcare. It's fair to say that each forum left us with more information, but also more questions. Healthcare in America is a complex and challenging issue that isn't suited for simple answers. Tonight we will present proposed solutions and how they specifically reduce costs and increase access. We should note that the planning committee of these forums has never adopted a stance in which costs were reduced without increasing access, or access increased without reducing cost. To us, neither of these approaches represented a solution. We are also aware of the healthcare cost, the relationship of healthcare costs to the nation's economy and the national debt and deficit, and agree that is a compelling reason to reduce the cost of healthcare. But do not think that healthcare should be reduced to such a low priority that our citizens cannot obtain the healthcare they need in order to be productive and responsible citizens of our country. Our message has been and is that significant reform is needed in our healthcare system. Lowering costs without significant reform will result in cost shifting mostly to consumers, increasing unaffordability, and declining access. Increasing access without lowering costs and without attention to the supply of healthcare providers will result in even less access and lower quality, not to mention an ever-increasing deficit. It is around these points that we planned our program for tonight. Before we begin, a few words about our sponsors, benefactors, and the League of Women Voters. First, we are pleased to share sponsorship of these forums with Olympic Medical Center. Along with supporting some of our advertisement and speakers' expenses, we also had on loan from OMC the expert technical help of Vicki Dumont for our audiovisual program. We also thank James Tracus, who is and has filmed and edited our last two forums, so we can post them for people to see and use them in other forums in the community. We are more than grateful to Peninsula College, who has given us the use of this fine venue, the Little Theater. We should note that we have received excellent help from the college staff in preparing our forums, and all that without cost to the League. Most important, we want to thank you for coming and helping us achieve our mission of encouraging informed and active participation in government around the pressing issues of our day, in this case, healthcare. We also want to thank those of you who were able to donate to support our forums. Our speakers have been generous in not charging us a fee, but we want to reimburse them expenses for coming to our community. So far, we have received nearly $500 in donations, which covered expenses for 2 of our speakers. So thank you very much. Again, in the interest of disclosure, we want you to know that the League has developed position statements in some areas and not in others. In the case of healthcare, the national, state, and county leagues have a position on healthcare which is in support of universal access to affordable care. The county's position also includes support of a single-payer solution. The League's websites have been included in the program if you wish to read the position statements. Tonight, we hope to have up to 30 minutes at the end of the program for audience participation. By audience participation, we mean we will open the mics to questions for the panelists. You may have a point of view you want to share, but we ask you to be brief and present it with a question. Timers will be alerting me if you go beyond 30 seconds, and I will call for your question. To help you plan your question for the most clarity, you should have been given a card on which to develop your question before getting to the mic. If you prefer, you can write out your question and a league member will read it for you. Be prepared to give your name and place of residence when you speak and provide it on your card to be read. I hope you picked up a program on the way to your seat. The program has the agenda and the background of our esteemed speakers and panelists this evening. Please read about them and their accomplishments. A bibliography is also in the program. We are asking you, and please help us out, complete a survey about the forum series and those you attended, including tonight. We want to know what you think. There will be a box to drop your survey in as you leave the theater. We are recording the program portion, but not the open mic for future use in the community. Please note that we time our speakers and give them the courtesy of alerting them when they are close to the end of their speaking time. The forum will end at 9 o'clock. There are no long breaks planned, so feel free to get up, stretch, and leave the room if you need to at any time. Let's begin our program. In doing our research, we came across a graphic from the Institute of Medicine's website that was developed around two Institute of Medicine, which I'm going to be calling IOM, reports that outlined ways in which healthcare costs could be reduced by taking up to $765 billion of waste out of the program over 10 years. The website and reports are listed in the program's bibliography, and I encourage you to review it, although I warn you, these are long papers. He's read them all, I can tell. He's laughing at how long they are. We thought that any actual or proposed solution should address some, if not all, of these areas. So I am going to take you to this website. If this shows you nothing else, it will show you the complexity and multifaceted nature of our system and its fixes. Please watch closely because the first two slides are automatic and they move somewhat quickly. The first compares the rate of increase in salaries versus the rate of increase in health insurance premiums from 1999 to 2009. Then it goes on to compare, well, what would happen if that increase was applied to the price of eggs or oranges or milk. I'm not particularly fond of this slide because getting eggs to market is a lot less complicated than getting a physician to market. What I do want to bring to your attention is the areas in which the IOM report says we have considerable waste in our healthcare system. And this identifies the areas, and I'm going to show you, if you want to do this at home, how you can, when you click on one of these areas, it shows you the areas that they are speaking to when they talk about reducing waste. I am not going to be doing that tonight because it would take too much time. But what I want to tell you about, these figures too, they're from 2009 and identified waste of $760 billion, which represents 30% of the total cost in 2009. This is an astonishing figure, but no doubt has grown in the last 3 years. Let's quickly look at the detail. Unnecessary services, $210 billion of waste. No doubt in part driven by the fact healthcare services are rewarded for volume. So the more tests, the more visits, the more medicine, the more you have, the more money that goes into the system. Getting something you don't need. a test that's not really necessary to your diagnosis, a medicine, a treatment, seeing the doctor more than you really need to, defensive mechanism, having an MRI when maybe an X-ray would do. Excessive administrative costs, probably brought on by excessive insurance companies, with their own, each has their own set of rules and forms and requirements, which means more billers in doctor's office, more billers in hospital, more paper, and more cost. Inefficiently delivered services. We should be going to the emergency room for medical emergencies, but not for sinus infections. Prices that are too high. I laughed at this when I thought, well, of course, that's the problem. It costs too much. But what this does is take it a step beyond that and says, prices are higher than they need to be to stay competitive. Higher than they need to be to stay competitive. So think about what that means. Fraud, live with it. It's never going to go away. This unfortunate reality enabled by our failure to enforce, but mostly our failure to detect fraud. The strange thing is, and I know if Eric could speak to this, he would agree with this, is that institutions and doctors are required to do more and more documentation to prove their accountability. That's costly because somebody has to do that documentation. That costs money. But there's still fraud. Highlight missed prevention opportunities, and you're going to hear more about this later tonight, and it identifies waste at $55 billion. I think that's seriously underestimated. We are terrific at saving lives and curing diseases, but we don't do a good job of prevention. Can't help but believe if we did, we'd save a lot more money than that. Now, to further demonstrate the complexities, let's take a look at the fixes that the Institute of Medicine reports. This report identifies 10 strategic areas for reducing waste by $463 billion. Instead of going through each one of these, which would take way too much time, I'm going to tell you that themes are the emphasis of the fixes. First, a fix. Electronic transmission of information between providers and payers, between physicians, between hospitals, between departments. You've heard recently that Olympic Medical Center is investing in and is incentivized to purchase an electronic system, and that's intended to streamline administrative costs and improve hospital efficiency. They don't want to say that money. There we go. All right. Evidence-based care, second one. That's a little harder for me to explain. It's kind of what I consider kind of an industry jargon sort of thing. But essentially what it is applying and paying for the most current and scientifically evidenced diagnostic procedure and treatment. Who knew we weren't doing that now? Obviously, professionals have to be involved in determining what is the evidence-based treatment, but what the system is saying is that it only wants to pay for those things that are proven of value in the treatment, the diagnosis, and the treatment of your condition. It also will decrease the cost, but also makes provision that will reform medical liability by creating safe harbors. And payers will pay attention to whether or not that expensive test was really needed for the diagnosis of your condition. One of my favorites, instead of rewarding for volume of services provided, design insurance and payment to reward quality and outcomes. Some of that is happening right now, and that will make a significant change in cost. Provide financial incentives to reduce unnecessary services. From my reading, these financial incentives are more like financial punishment. The most recent one you've read about is that hospitals will either not be paid or have to pay for unnecessary hospital readmissions. Providers are also asked to think about what does that patient, providers will not be paid for costly tests that were not necessary to the diagnosis and treatment of the patient. So reducing readmissions, preventing errors. Another favorite of mine is coordination of services, not only through electronic transmission of relevant information, but also by intention. Put the patient at the center of care. Providers are asked to think about what does that patient need when they leave their area, and will they get it? It's saying that if we can have early intervention and better coordination between physicians and decrease the severity of illness, well, maybe we'd have less hospitalization. Fraud and abuse, yeah. Fund detection. The last one I'll emphasize is an extremely important one, which again you're going to hear more about later in the program, and that's called increased shared decision making. And what that means is more and more people getting active and responsible in their own care and their own decision making related to their health. Being an informed consumer means being aware of the cost. What is it costing? Being an active partner. And I think this is also seriously underestimated if that really can be put into place. Okay, this is difficult work. There is no magic payment plan that will get us there. We need a reform of the payment mechanism, reform in incentives, reform in the delivery system. There is no simple answer, which brings us to our speakers tonight. Our speakers tonight will focus on the Affordable Care Act, called Obamacare by some of us, the single-payer solution, the importance of prevention and health care in rural areas such as ours. Some of you may be disappointed that we are not presenting solutions such as Premium Support Program, also known as the Voucher Program, or various tax incentive solutions, and we need to tell you why. I started this forum by telling you that the thrust of our series has been the imperative to reduce costs and increase access, and that one without the other was not a solution. We were unable to find the detail of proposed premium support, our voucher programs, our tax incentive solutions that would support an increase in access to affordable care. Also, the voucher program only deals with Medicare beneficiaries and promises the repeal of the entire Affordable Care Act. It also promises cuts in the current Medicaid program, both of which to attempt to increase access for people in need but not eligible for Medicare. Tonight we present programs that attempt to do both, reduce cost and increase affordable access. You can assess whether they do or not. We have asked George Martin to instruct us on the ways in which the Affordable Care Act and the single-payer solution would reduce costs as identified in the IOM report we just reviewed and maintain or increase access. George Martin is an MD who practiced as a pathologist and a very accomplished physician and researcher. He is renowned in his field and in his ongoing studies and research, particularly as it relates to aging and the development of chronic disease. When George and I first started communicating about the forum, he was traveling to Oslo, Norway. Curious, I asked him why, and he nicely told me about it and sent the link for the Genome Dynamics and Neuroscience Conference, in which he spoke. The agenda was written in English, but it might as well have been written in Norwegian, as advanced as it was. You will be awed by the contributions of this physician when you read his bio in the program. But tonight, George has turned his considerable background to the need for healthcare reform. He is a member of the Physicians for a National Health Program. He is here with that interest this evening. Please welcome George to our community.
Can you hear me out there? Yes. I have a propensity to move around, so I have a lavalier microphone. First of all, I have to give a full disclosure. I'm a complete neophyte in the field of health economics and healthcare. As you heard from Bertha, I'm trained as a pathologist, and for years and years, I've tried to build a good relationship with my patients at the autopsy table, but I can't learn anything about how good their health care was or how much it cost. But I'd only recently became interested in this very important question, and I have to tip my hat to people like David McClanahan here, who'll be talking to you later. And everything I've learned from my colleagues here in Seattle and from the National Physicians for the National Health Program, which I relatively recently joined. So let's get on with this. This is the outline of what I have to say. I'm going to give you a broad, quick look at our healthcare problems. I'm going to tell you about a preferred solution, which I feel is just obvious to me and to all my colleagues, a single-payer plan, and I'll go through that. I'm spending less time on the Institute of Medicine. This is really related to the Institute of Medicine. Why? Because in the report that Bertha mentioned, I think it's 860 pages, that's 2010, and one that's recently coming out, 2012, and I have in that folder there, the entire report is about 386 pages or thereabouts. There's no addressing to a systematic look at the system. And that's what we need. It's astonishing. Single payer, I looked at the search technique to find all references to single payer in this newest document, and it was only mentioned once in a tiny paragraph about the state of Vermont. And they're avant-garde in trying to do this. So it surprised me and disappointed me about my colleagues. I'm a member of the Institute of Medicine, although they don't ask me about healthcare economics because I have no background in it. So then I'm going to tell you about the Affordable Care Act, and many of my colleagues are disappointed in that it doesn't go far enough, and it basically locks in the present system. A little bit more about the Institute of Medicine reports, and then if there's time, and I rather doubt it, I'm psyched out by these 30 seconds, 10 seconds. But if there's time, I'll tell you about something I do know about. That's the basic research and the promise of basic research for addressing what's a core problem, because the demography, the projections for demography are increasing aging population. Do you know the fastest subset of our population, the fastest growing subset? Centenarians. And with that comes exponential increases in chronic diseases. So if we could slow the rate of aging and compress morbidity, we would save huge amounts of money. So if we have a little time, maybe in the discussion, I can show a few slides about that. So quickly, first I want to talk to you about, again, something I learned from my colleagues on Western Washington chapter, Physicians for the National Health Program. This article by Deborah Stone at Brandeis University, there's a picture of her here. And this is a very important concept. It has to do with the vision of what she calls distributive justice and which it governs. And there's two contrasting principles. Maybe, Bertha, this was talked about in the second ethics meeting. But there's a solidarity principle. That is, will a community, society guarantee the basic needs for all members of the community, and they're paid by the entire community? That's a fundamental concept of distributed justice. An alternative is the principle of actuarial fairness. That is to say,
move your microphone towards the center. It cuts out
completely
when you
thank you, son. That's
your microphone to the center.
okay. My microphone to the center. Well, that's a bit of a problem, I think. You're right. I'll hold the microphone. Here we go. Yeah. So anyway. How's that? Better? Not too loud, is it? Okay. So, the principle of actuarial fairness, and that's the notion that why should I pay for somebody who has a higher risk than I do? And so that's the notion of selecting within the community subgroups by subgroups. You're dissociating the community, so to speak. And people in the Affordable Care Act, there'll be a different premium for people who smoke. So you don't want them in the same pool. So there's a little mixture of those concepts there. So in the discussion, I would like to learn from you folks here what you think about these two contrasting principles. Where do you stand, and how should our society move in this direction? So now, I went to a national meeting of Physicians for National Health Program, the first one I went to, and we had a wonderful visit from an English radiologist named Jackie Davis, and she summed up beautifully the present situation in the United States. And this is the quote, which my son Peter remembered exactly. He wrote it down. She said, well, she was very glad to be in America. She said, I come from a land of socialized medicine to islands of excellence in healthcare here, in a sea of misery. And basically, that's what we have. You can get the very best healthcare in the world here, places like the Cleveland Clinic, and the Mayo Clinic, and in the state of Washington, excellent service. But there are a lot of people who are in misery in terms of healthcare. That's our problem in a nutshell. So quickly, life expectancies compared to other developed countries around the world, we're right at the bottom in terms of life expectancy. Now it's too loud. Infant mortality, we have the highest infant mortality of all the developed countries. This is my favorite slide, the number of uninsured Americans over time from 1976 on. It's a tremendous increase of uninsured individuals. The number of adult deaths annually due to uninsurance, 44,000. That was in 2009. David McClanahan showed you some data showing that in the state of Washington, 2006, there were over 780 deaths that could have been prevented easily because of lack of insurance. Medical bankruptcies. About half of all personal bankruptcies are due to medical problems. And 76% of those people, they had coverage, but it was not good enough coverage. Now the spending, this is more or less addressing what Bertha did, but on an international level, we're number one in terms of spending. So we rate near the bottom or at the bottom amongst the developed countries, and we're spending twice as much. Right now it's about 18% of the gross national product, and there's some predictions by mid-century it'll go to 30% of the gross national product. That's not sustainable, so it's a terrible problem. So what are the drivers of the healthcare cost? John Gaiman, who is chairman of our Department of Family Medicine at the University of Washington, he's written 3 books on the subject. And still very active in the field. Here's his list. As I mentioned, I have a special interest in number 2 and number 3, and that could drive down the cost if we understood mechanisms of aging. Technological advances, increasing inefficiencies and redundancy of private insurance. You've heard this from Bertha. She's given some statistics on how much each contributes. Here's the growth of administrative costs. In fact, at Duke University, they have about 900 or 1,000 beds at the University Hospital. You know how many clerks they have? I think it's about 900. It's damn near one clerk for every bed. And so we would like to have a nurse for everybody that you don't have. So now here's a preferred solution, a single payer. What is it? This is some slides I got from Bill Shaw, who's a distinguished health economist at Harvard. The definition that it's a single risk pool. Everybody is the principle of sharing in the community. It's a single benefit package, a basic package. It's a single payer of providers, a single bargaining agent, which saves a lot of money. We pay like 45% more for drugs than any other developed countries because we don't have a single bargaining agent. The exception is the Veterans Administration. They do have a single bargaining agent. They are a single bargaining agent. And typically, the government runs it, and in the United Kingdom, it's socialized medicine, but it doesn't have to be socialized medicine. And in our program, the Physicians for National Health program, we conceive a single payer who's dealing with individual private clinics and private hospitals. It's not owned by the government. Now, closer examination, it's a means to an end. And so it's risk pooling, pool together health risks of all citizens, equity in distribution and financing burden, uniform premium rate, equity in benefit, manage the expenditures, single payer providers, manage quality of patient care, manage providers, and uniform electronic records you've heard about, which incidentally is also, this system is also very important in epidemiological research. And it's not mentioned enough that that's a major advantage of that. For example, the Veterans Administration, they had a single payer program, very good electronic records, surveillance, and they're the ones who really came up with the evidence of the importance of antihypertensive medications in preventing strokes and heart disease. Okay, now look at Canada has a single payer system, and look at the rate of their increase of costs in yellow versus in the United States. Our rate of increase, as I mentioned before, is much higher. Now, here's an example of what you would save if you did have what we call a Medicare for all, or an improved Medicare for all. You would save covering, you have some additional costs because you have to cover the uninsured and poorly insured. You have to eliminate cost sharing and co-pays, but these are the savings, and the total savings you get from all these approaches give you a net savings that's very substantial. Now, there's some things that it's not worth worrying about too much. For example, here, do you have to pay for your paper and plastic here in Port Angeles? We do in Seattle. We have to pay for it. So, but my colleagues really went to bat for this, and there were a group of 8 who went to the Senate Finance Committee, which is chaired by Max Baucus, a senator from Montana, and that was the key committee in discussing how we would do healthcare reform. And they wanted to discuss a single-payer program, and Senator Baucus said, this is off the table. We will not discuss it. So they decided the only way to go is to do what the civil rights people did, civil disobedience. So they showed up at the hearing, and they shouted out, Senator Baucus, why not even discuss a single-payer approach? And they called a sergeant of arms, and the police arrested them, handcuffed them, and booked them. So that's the interesting thing is we've heard virtually nothing about this in the major media. So it really didn't achieve that much. This is a young internist who was also a young female pediatrician who was also arrested. Now it turns out that Most people prefer Medicare for all, and it's a relatively recent survey. 59% that the government should provide national health insurance. And what's not appreciated is that physicians now support it. Over half of the physicians like the idea of a national health insurance and an expanded Medicare. So that's a little misconception. Physicians support it. Now, what about Obama's single-payer plan? Single-payer plan is what I would like to see, he said when he was addressing the AFL-CIO in Chicago in 2003. Here's what he says in 2008. If I was starting from scratch, if we didn't have a system in which employers had typically provided health care, I would go with a single-payer system. So he had then this is a putative solution, Affordable Care Act. He did not want to start from scratch. He made that decision. He had these two fundamental choices. One, to build on the public sector, Medicare, or Medicare for all, or to build on the private sector, and he chose that to build on what he had. So what that produces, certainly a lot of good things are in the Affordable Care Act, and this is a very brief summary. I gave a reference to a book by John McDonough in 2011 that goes through the whole thing in great detail. There are more people are covered, yes, but there's still between maybe 25, 35 million people still will be uninsured. 30 million is the figure that you also offered here. More benefits, more protection, lower costs, improved quality, stronger workforce, greater focus on public health and prevention. So there are some good things in that act. Now, with the Institute of Medicine, the most recent report here, this 2012 report, there are 18 members on the committee, and there are also a number of reviewers. Not a single member was represented Physicians for a National Health Program. They included people who were in industry, the CEO of WellPoint and the Vice President of United Healthcare. So many of us feel that this is a conflict of interest. And there was, they said, no recommendations for a fundamental structural change in single payer. So the recommendation that cost rather than medical need be the basis for defining essential benefits package, that prompted a letter of protest. And I was among those people who signed that letter of protest, even though I'm a member of that organization. I think they could have been done better, but they did indeed have useful suggestions, and I feel strongly that if that's the law, we're going to live with it, and we want to do the best we can under that system. If there's any way we can tweak the system and make it more equitable and cost-effective, we should certainly do that. So, going back to the Institute of Medicine, one very good thing they did back in 2007 is to focus on this problem of medication errors in hospitals. And it's astonishing how much that is. That it cost us in 2006 dollars, it cost $3.5 billion in errors in medication. Either penmanship on the part of the physician, that's been ameliorated by electronic records to some extent, or filling a prescription in a retail drugstore. So that was good to bring that across. This, I won't spend time on it because Bertha really has gone over this. The systemic waste across the board, the famous 30%, $765 billion. Some people disagree with the exact amount, but it's a lot of money. What other good things they've done is to point out the variables of disparities in health. Education, for example, as you see from this histogram, a big difference in outcomes has to do with your educational attainment. So it means that part of our society is going to have to move more vigorously to better education. Ethnicity, here's an example of the difference in healthcare amongst different ethnic groups. our own Native Americans in terms of diabetes, how much poorly they do in mortality rates compared to Caucasians. Very striking figures. Change income. Income at the basis, the most important aspect is this social aspects of the individual, which in turn is this socioeconomic aspect. So people with income differences have been increasing dramatically around the developed countries of the world, including the United States. And so you could predict that that's going to produce more disparity in health. And we're beginning to see that already. So now I can't have time to go through the several individual recommendations that were made. Here's just one example. I mean, they gave lots of examples of what can be done and what is being done. This comes from Kaiser Permanente. This is called the Healthy Bones Program, and they wanted to reduce the incidence of osteoporosis and hip fractures. So they worked with their orthopedists, and they set up a program which here's a case where they increased medical scanning. The DEXA could scan how much, make a diagnosis of osteoporosis early on, and they were more vigorous about management by medications and non-medication procedures. And that gave them quite significant results. So they reduced the hip fracture rate of the at-risk patients by nearly 50% by this focused program. And there are a lot of other wonderful examples. I want to refer you, however, to something that's not in your handout, but I just learned it recently. T.R. Reid, the journalist, his book is in your handout, but recently he has a new video. It's called The Good News in American Medicine. And so what he's done is to flesh out solid examples of what the Institute of Medicine has been talking about, things that can be done. And it's entertaining and interesting, particularly because there's a big focus right here in the Pacific Northwest. In the group health, particularly the Factoria unit in Bellevue Group Health, and in the Everett Clinic. At Everett Clinic the people at Everett Clinic were asked by Boeing Company to introduce their special patient management techniques, particularly for chronic illness, which has saved them a lot of money and saved Boeing a lot of money. That's a problem. Sorry about that. And the Providence Regional Medical Center in Everett, they accept everyone, those who are even without insurance, and they spread their costs, as does the group in Grand Junction, Colorado. The physicians gathered together and they decided to pool all of their remuneration from every system and spread it around, and had other innovations. The Dartmouth Hitchcock Medical Center is focused on. What Bertha mentioned, they focus on the participation of the physician and the doctor in making a decision. The example they give is a hip replacement and a herniated disc. And they save a lot of money that way, and the patient really helps to make a decision on whether or not it's worth doing this intervention when there is a potential side effect or not a side effect. So that is translated into happier patients and cost effectiveness. Now I'm going to end. How much time do I have? I have a little bit of time? Okay, so I can show my stuff on aging. Great. So I just wanted to remind you for the discussion, I would like to get your feedback on how you feel about those two contrasting principles, because that's at the basis of everything. And as a people and a community, we have to come to grips with that. So, promise of basic research. Gosh, I could have given 50 slides, but I just, it was very painful to get down to just about 4 or so. So first I wanted to follow up with some numbers on U.S. Census estimates of the relative change of the size of the population. And here you can see that subset over 85. That's the big one that's growing. It's unprecedented in history, this growth. And I mentioned even centenarians. And this is a graph. It's a graph which shows on this axis here, this is a logarithmic scale, and this is a linear scale. So you can see that this is what's called an exponential function in the prevalence of dementia of older people. And if it were shown in a regular way of the graph, it would go something like this, boom up as we got older. And after the age of 85, about half of the population will have dementia. Now, 60% of them have dementia of the Alzheimer's type, the most common, but there are frontal temporal dementia, a different type of dementia. There's also something called Lewy body dementia, which is associated with Parkinson's disease. There's multi-infarct dementia from little tiny strokes, and very often the little tiny strokes with Alzheimer's pathology produce dementia. And there's some rare types. But here in a study that we did at the Alzheimer's Disease Research Center, along with Eric Larson at the Group Health Hospital, there we found that up to 70% of all the residents in a nursing home in Seattle for Japanese individuals had a dementing illness, a remarkable prevalence. But you can see all cities around the world, they're all showing this dramatic thing. And one problem, as I look through the literature, is that nobody's really come to grips with the cost of long-term care. Medicare does not cover long-term care. And so, actually, my late wife's younger brother, who's now 81, just entered a nursing home with dementia. And I think the cheapest reasonable place that the family could afford is about $5,000 a month. It could easily be $10,000 a month. So the disease could be in a nursing home for 8 years is a kind of a typical thing. That's an enormous cost. So that's something we really have to come to grips with, and we hope that research will be able to ameliorate that terrible problem. You don't want to have your last years of life being demented. Finally, I just want to show that there's a very exciting progress in trying to understand aging. I won't go into great detail on this, but I'm just telling you that for multiple different organisms, yeast, worms, little nematodes, fruit flies, Drosophila, laboratory mice, and humans, there's a common biochemical pathway that when you tweak it a little bit by making what we call leaky mutations, these individual animals can now live much longer. Now, the extent to which that longer life is associated with longer health span is still actively being researched. And we don't know enough about the normal physiology of fruit flies and little worms called Caenorhabditis elegans to really come to grips with that. But people are looking at that now with great attention. And there's some evidence from a colleague in Boston who is studying centenarians in the New England area, that the centenarians are having some compressed morbidity, that they're healthier for a longer period of time. And there's also those individuals who are centenarians. Guess what? They have an enrichment in a slightly different form of the gene, which is the key gene in this pathway. It's a gene which is where it was first discovered in worms. It's called DAS16. It's a transcription factor. So a transcription factor is controlled with lots of other genes. Just one gene is a master controller. And it turns out that the centenarians, they have a gene which is homologous to this gene. It's called FOXO3A, and it's that variant of it is increased in about a half a dozen different studies now. all over the world in centenarians. So there is a chance that we can slow aging. So I'm going to stop there, and I still have some time. One, maybe. Okay. This is a beautiful campus, a quad, and many of you got your degrees there. Thanks for your attention.
Thank you, George Martin. Don't y'all feel good that we have people like this working on our aging? The other thing that really feels good, George, is you obviously enjoy what you do. We have asked Tom Locke to instruct us on why prevention is a key to reducing costs and what communities and individuals can do now and in the future. Tom Locke is known to many of you, probably all of you, and certainly is known to the League of Women Voters. He has spoken at numerous forums in his role as a strong advocate for community health, particularly the very special rural communities in which we live. Tom has a gift for being able to speak understandably and meaningfully about complex issues and their effects on our daily lives. We all listen when Tom speaks. Please welcome Tom.
Thank you very much, Bertha. So is this sound okay? I should adjust it. Well, as always, it's a real pleasure to have the opportunity to talk about issues like this. And I've carved out a ambitious chunk of material to try to cover tonight. And so if I seem to be rushing through it, there's a purpose to that. Hopefully it'll hold together, and it'll be worth going through all these three main areas. I will take a clicker down there. In my haste to escape the Jimi Hendrix recital there. Okay, so these are the areas that I'm going to try to cover. Starting with a bit of data about the area of Washington that we live in, rural Washington, and how health reform for us needs to be fundamentally different than the urban model, which is really what the national efforts are based on. Second, I want to introduce folks to, and hopefully a lot already know about the triple aim and what that's all about. Third, I want to talk and make the argument that we are entering into what people have called the era of the empowered patient. And that's going to make a big difference in how health reform plays out. And then finally, to talk as much as possible about what we can all do as individuals, as members of families, as members of the community to make this happen. So starting with rural Washington, this is the basic layout. The colors are not great on this, but basically it ranks things from small towns, large rural, suburban, to urban. And up here on the Olympic Peninsula, we are really between isolated rural and large rural town. I noticed the map makers got Jefferson County a little wrong. They seem to regard the Mount Olympus area as being a large rural town. In fact, we all know it's the Quimper Peninsula over on the east is where everyone lives. But this kind of shows you the distribution. And essentially in those darkest areas, that's where 80% of the population of this state lives. The other 20% live in the rest. And this is very similar to the statistics for the whole country. We're about 80% urban, 20% rural in the United States. It also has significance in terms of our age distributions. The picture on the left is the distribution of people over age 65. And as you can see, the Olympic Peninsula, we are the oldest area in the state. We are not only above 20%, we are approaching 25% in central and eastern Clallam County and eastern Jefferson County. Squim is the official oldest mean age in Washington State as a city population. And the flip side of that is over on the right. Just as we have the highest percentage of elders, we have the lowest percentage of adolescents and children under age 18. And that has real significance because the basic design of Social Security is for the younger people to support the olders. If you look at the boomer age group, so those born between 1947 and 1960, our age skew is even more dramatic. We have a huge wave of boomers on the verge of retirement on the peninsula here. We're also different in terms of income. Our per capita income is significantly lower than our rural counterparts, and our urban counterparts, and our poverty rates are higher, rural as opposed to urban. We are sicker, and we become injured more often. Just one example is heart disease. It's highest in isolated rural, a little bit lower in large towns, and then significantly lower in urban populations. Likewise, unintentional injury or intentional injury, suicide are both higher as you get into more rural areas. Our risk factors are higher in rural areas. These are the statistics for smokers over the last 5 years that we have data. Urban populations, significant drops. Isolated populations, not that many, not that much of a drop. And you know, this is among the worst of the risk factors. If you look at other ones, substance abuse, alcohol abuse, illicit drugs, they're all higher in rural areas. And the one we're especially talking about tonight, access to health care, this is worse in rural areas. So adults with insurance are the lowest levels in rural areas. Adults with access to dental care, adults who can who have a identified personal health care provider, all lower in rural Washington. And then one of the most significant is our workforce shortages. Here in Washington State, we have 20% of the population, but we only have 9% of the physician workforce. And for other health professions, it's very similar. So it's a little higher than that for pharmacists, a little lower for mental health therapists, but even the best statistics are around 10 to 11%. So we have that mismatch going. Not only do we have that ratio being off, but our workforce is older. Average nurses in rural Washington, or average age of nurses, I believe is currently 52. Physicians, not much different. And that means they're closer to retirement, and are going to need to, their replacements are going to need to be recruited sooner. We're looking at shortages of virtually all healthcare workers as this boomer generation ages and moves into retirement. And our training programs are not keeping up, although there is some encouraging news in just the last couple of years. Training programs for nurses are generating more nurses. Family practice programs, especially at the University of Washington, it's been one of the most successful programs in the country in terms of getting people into primary care specialties and getting those specialists out into rural areas. But we have a huge distance to go. So my basic argument here is that we need a different model than the urban model. The Affordable Care Act is basically a managed competition model. Insurance companies compete with each other, and healthcare providers and hospitals, they all compete, and competition, as we all know, just makes everything better. What I would call the repeal plans, which are being discussed in this election season, basically just go back to the status quo. Their only real new idea, and it's not a very new one, is that insurance be sold on an interstate model. So you have interstate insurance competition. What I would argue is in rural Washington, our reform is not going to be competitive. It's going to be collaborative. It's going to involve coordination of services, careful stewardship of what are always going to be scarce resources. And we have to, we can't afford wasteful duplication or extra infrastructure or duplicative services. We have to do everything possible to avoid that. And I won't go into any more detail on this. I just want to refer you to a very interesting project that I and a number of others have been involved in almost for the last 4 years. We came out with the first comprehensive strategic plan for rural health care in the state about 2 years ago. We've just reissued an updated version of this about 2 months ago. At the very bottom is the URL. Really all you have to do, if you just Google, Rural Health Strategic Plan for Washington State, it'll take you to this site. Or go to the Washington State Hospital Association and Google strategic plan. And that it's about 40 pages long, has a very detailed outline. This is one of the summary graphics in it that kind of gives you a preview of what the plan is. The top part of the diagram deals with these sort of problems we're facing that all result in the common problem of inadequate access to health care. The redesign of the program focuses heavily on rebuilding, reintegrating, or reinnervating, I should say, this concept of the medical home, building regional systems for care for the things you can never really do in a rural area, like heart bypasses and burn units and advanced neurosurgery, and then transforming the inpatient experience. And here's my favorite part. Here is the radical idea in this diagram, and that is the scorecard for all of this. It is not the volume of services or the complexity or the cost of them. It's the outcome on community health. That's how you measure whether you're successful or not. And it acknowledges, too, it's not just the healthcare system that produces community health. There's a whole bunch of other community systems that do that as well. So, if that's your scorecard, what exactly does that mean? What are community health outcomes? We're familiar with a lot of the traditional ones, like infant mortality, life expectancy. There's others, more sophisticated ones that take life expectancy and factor it into what kind of quality you had during those years of life. That's called quality adjusted life years. Or you can flip that around and look at premature mortality and figure out how many years did you really lose. Someone dying of cancer at age 20 and age 80 has a very different impact on society. We have all kinds of measures of disease rates and accidents and injury rates. Those are the kind of things that will become the new scorecard for our healthcare system. But I think the most ambitious and the most visionary of all of the outcome goals is what's called the triple aim. And this is something that was developed by two people at the Institute of Healthcare Improvement not that long ago, really. And they had the insight that you have to do three fundamental things to reform the system. You have to use population health as your scorecard. That's the ultimate goal. You have to improve the patient experience of care, is the words they chose to express that goal. And you have to reduce or at least control the cost on a per capita basis. And not only do you have to do these things, but you have to do them simultaneously. You can't pick two of the above. You can't do one of three and put the other two off. It only works if you're doing all three simultaneously. And I won't go into the argument for why we need to control costs. I think this one graph, to me, just says it all. This is life expectancy when compared to the 34 other leading industrial nations. And top graph is, or the y-axis is life expectancy at birth. The x-axis is per capita cost. We've clearly won the health Olympics when it comes to cost. We're out there on the far right with our gold medal in cost. But that's really not what the health Olympics are about. They're much more about life expectancy and quality of life. And the ones really winning that are Japan and Switzerland and Italy, Sweden, who are doing much better than we are, in many cases, at half the cost. The patient experience of care is a very interesting way to roll up all these different measures of quality and safety and effectiveness and efficiency. And the key thing there is the real value that you're looking to increase is from the perspective of the patient. The only real relevant measure is from the person that the system is supposed to serve. Having your MRIs running night and day is really a value to a hospital's bottom line, but not necessarily a value to the consumers of those services. The patient experience of care also means that that patient has to have full access to their information, something that wasn't really possible until fairly recently, but now is very much possible. The patient experience of care means that the care has to be truly patient-centered. Right now, our system is provider-centered, and it's not done in a malicious way. It's just the design. Appointments are structured around the needs of the organization, not the needs of the patient. There are ways to change that. There needs to be an increased focus on chronic disease management, more time spent on that, and less time spent on routine care that can be done in other ways, that can be done by email. Most cases, to refill a prescription, the reason you go in and see someone now is that allows them to bill you for that service. You change the rules and you can do it by email, that service delivery will change. So there's a lot of things that, ideas that people are putting in practice to improve the patient experience of care. I don't have much time to go into the details, but a really fascinating example of what is possible is what's called the NUCA project. This has been going on for the last decade by the Alaskan South Central Foundation. This is the Alaskan Native Corporation that provides healthcare services to Alaska Natives that live around Anchorage and the rural areas served by Anchorage. They have one of the most difficult patient populations in the country to deal with. Huge rates of isolation, substance abuse, and domestic violence, and high-risk pregnancy. 65% of their pregnancies are high risk. Diabetes is an epidemic in this population. Their costs were out of control. And so they did a fundamental redesign of their system to focus on patient empowerment and intense education and outreach and developing these medical homes, and teams of educators and providers. And their 10-year results are starting to come out. and they're incredibly dramatic. ER visits are down 40%, hospitalizations have dropped 75% in this population, specialty care is down, even routine doctor visits are down significantly. And measures of health within that population are all going up. And it's, Google this and read about what they actually did. You know, it's a very ingenious, patient-centered, community-focused approach to re-engineering health services. So now my favorite area, you know, population health, the new scorecard. And when it becomes a scorecard, we're really not going to be looking at volume or cost or complexity anymore. Those in many ways are more problems than they are goals. What we are pursuing is value, which is a relationship between quality and cost. Also, to understand population health and how you improve it, you need to understand what are the determinants of health. What makes you healthy, what the lack of what makes you less healthy. To achieve these goals, you know, we can't create a brand new system. We have to use the existing players. So a system that is focused on improving population health will also work to integrate the public health and medical care organizations that exist now, and we'll integrate them into a system that has three key attributes. It's community focused. You know, for instance, here on the Olympic Peninsula, we need to focus on our population demographics. We need to focus on the fact that we have a lot of Medicare eligible patients, and it's only going to increase. Now that has huge effects on our system design. It has to be patient-centered, and it has to be outcome-oriented. And it's got to make investments in things. You know, not only healthcare services, but emergency preparedness. We've been learning that over the last decade. There's a lot of investments in healthy communities that don't have to do with your healthcare system. They have to do with your sidewalks and your recreational opportunities and preventable violence. And you have to invest in information systems that give people access to the information they don't need to make better health choices, and also to evaluate whether what you're doing is working or not. So just a few views on these. This is a slightly different version of the determinants of health, but essentially accurate. You know, a fair amount of it is genetic. It's the hand you're dealt. A fair amount of it is behavioral. It's the choices you make. Social circumstances, you know, where you live, what kind of job you have, what sort of social support service you have are very significant. Exposure to environmental toxins is significant. And healthcare is important, very important, but it's 10% important as compared to all these other things. This is another way of looking at it, a little cartoonish, but it's, you know, this is a diagram that, you know, the hand you're dealt is your age, sex, and heredity. But then you have all these immediate social support services. And then you have a layer of all these healthy and unhealthy behaviors that you choose. And then you have a community with all its risk factors that you live in. And then finally, you have a nation, you know, that has a healthcare as a right and a single payer system, or not. Those things all make a difference. Those are determinants of health. We've been talking about the Institute of Medicine tonight, and the Institute of Medicine has been especially busy on this particular topic. These are 5 reports, you know, most of them several hundred pages long, that have looked exhaustively at these key issues. These are the titles of the report. So there's one on integrating primary care and public health, another on living well with chronic illness, one about investing in a healthier future, revitalizing law and policy, and the role of measurement in action and accountability. I'll talk a little bit about those. Most of these actually, interestingly, are just out in the last year, 2012. So the one that talks about integrating primary care and public health really looks at some important key principles. First of all, you have to have that unified scorecard. Population health improvement has to be the way you measure both public health and medical care success. You need to have a process that works bottom up, that's grassroots based. The community has to be engaged. But you have to have a top-down component to it too. The leadership of these different organizations have to adopt common values. They need to clarify their roles. They need to agree to measurable goals and outcomes. They need to be able to manage change and uncertainty. And whatever you do, it's got to be done in a way that's sustainable. It's wasteful and disheartening to start things only to have them collapse a year or two later. And it's got to be data-driven. You have to know whether something is working or not in order to know whether you should continue down that road. I won't read this list to you, but this is from the Institute of Medicine. This is what they feel are opportunities that are within the Affordable Care Act to do demonstration projects along the line of public health primary care collaboration. Community transformation grants are among the best. The Macaw Tribe has a community transformation grant. Living well with chronic illness, very interesting report. My one point here is that chronic illness management is not just giving some pills and a pamphlet. It's a complex system that supports that chronic illness. For the public health, it's about investing in this healthier future. And we lead the world in our investment in healthcare services, but we actually have one of the lowest rates of social service investment in the world. And that's important. I'm not going to explain this, but anyone wants to ask me about Frieden's pyramid later, I will do so. So let's move into personal action. I've got 5 suggested areas here. Number 1, starting point, we need to face facts. Current system is unsustainable, period. $2.6 trillion in 2010, over 18% of the gross national product. We will hit 20% in a matter of years. Number 2, healthcare reform is not just about healthcare financing. That's what all the talk is about. But the real work is much more complex. Our current system is produced by the incentives in the system. That's why we get the results we have. We need to change those incentives if we want different results. Same applies to our political system. I would argue our system is very well designed to get gridlock, to be manipulated by special interests, and to value short-term expediencies over long-term investments. Number 2, we need to avoid ideologic traps and diversions. I have a specialty in population health and preventive medicine. So I think that allows me, I have a legal right to make population diagnoses. And my diagnosis is we are in an epidemic of ideology and ideologues. This is the motto of the ideologue. I know what's right, don't confuse me with the facts. We need to fight that. We need to see that these, public versus private, big government versus private enterprise, these are all false dichotomies. All these entities can work together. We know a great deal about what we need to do in terms of quality improvement, patient safety, making communities healthier. The problem is we are not doing what we know how to do. And there's successful models all over the place. There's people doing it in the United States. They're doing it all around the world. We need to do more of it. As voters, we have a responsibility to look for problem solvers and elect them, not these partisan warriors who seem to have filled our Congress. Think locally, act regionally. There's a lot that's possible at the local, regional level. It's already happening. That healthcare providers and public hospital districts are working with regional partners. We have community health partnerships going. We need more of them. The key thing, though, we need to have a successful project is we need the authority to spend the money we're spending now differently. We need to reallocate the resources because that's the only way you can reward innovation and you can reinvest the savings. Becoming an activated patient acknowledges that most of those determinants of health are not within the control of healthcare providers. If they're in anyone's control, it's in each of us as an individual patient. Electronic medical records, the fact that we more and more of us carry very powerful computers around on our belts creates extraordinary opportunities. But beware, being an activated patient is not the same as being an entitled demander and wanting more and more services. This is my final slide. It's going to be a bumpy ride for the next 4 to 6 years. But if you remember one thing out of this talk tonight, it's that this truism, only things that can be measured can be improved. We've got to pay attention to the measurement. Start with yourself. Know your own numbers. And then get interested in community health assessment. And here's our cliffhanger. This is the final Institute of Medicine report, but if you want to hear about this, you have to come next week, or 3 weeks from tonight, where we will have completed our project, update all our local data about how healthy we are, and we really want to hear from all of you about, in that data, what's important and what our priorities should be. So thanks very much.
Well done, Tom. Thank you so much. Again, we should be impressed with the resources here tonight and the resources looking out for our health in the community. I'm going to ask Tom if you'd stay at the stage and George to come to the stage, and I want to introduce both David McClanahan and Eric Lewis, who have joined our panel. First, David McClanahan is a retired surgeon who has been active in Physicians for National Health Program and serves as coordinator for the Western chapter. Like George Martin, David was off to faraway places during our forum planning period. If you had read his bios, if you've read it, you won't be surprised. When we first spoke, he was somewhat complaining about losing his favorite shoes to the muddy field in Borneo. Do you remember doing that? Complaining or losing your shoes? Anyway, now I knew this had to be interesting. Turns out that David had recently returned from Malaysia, where he was attending a conference to further his work with artists and designers from Malaysian Borneo and India to help keep indigenous people's traditions alive by helping promote their textiles, handicrafts using traditional motifs and techniques. You all know Eric Lewis. Eric Lewis is CEO of Olympic Medical Center. He's been the CEO since December 2006 and was the CFO prior for 8 years. Now Eric and I came to OMC at the same time and worked together for 8 years, so I have lots of good stories about Eric. But I thought, in the spirit of tonight's introduction, I would just tell you all about his most recent travel experience, which was a 50-mile hike with his son and his son's scout troop. Please welcome David McClanahan and Eric. Because you're don't know David and Eric, and they haven't had a chance to warm up their vocal cords, I'm going to ask them each to give a brief statement. And David, would you start, please?
Thank you. First, I'd like to just say a few words about our organization, Physicians for a National Health Program. We're now into our 25th year nationally, advocating for a single-payer, publicly financed, privately delivered program that would give healthcare insurance and coverage to everybody every resident in the United States. It's been a long struggle, but we're still out there after 25 years. We have 18,000, 30 seconds left. We have 18,000 members in chapters across the country. Our Western Washington chapter was started about 7 years ago. We have monthly meetings where we bring in an outside speaker and focus on a topic. For November, the third Wednesday at Swedish Cherry Hill campus, we've got Eileen Cody, who's the chair of the Washington State House Health and Wellness Committee. Stop. I'm hoping I can, during the discussion period here, give statements on
we'll give you
PNHP
a few more
thinks
seconds.
about
Go ahead.
Okay.
We'll give you a few more seconds now if you'd like them.
Oh, well, I just hope we can talk about PNHP's position on the Affordable Care Act and how we think that expanded and improved Medicare for all would be a much, much better solution.
Okay, we will do that. Eric, how about a minute and a half for Eric? Eric, yeah, this is tough, isn't it?
Yeah, well, good evening, everybody, and I'm really glad that Bertha didn't go into any stories about me. But I really appreciate the League of Women Voters in doing all these forums. There's been a lot of great information tonight in the past forums. I just want to talk briefly about two things which I think everybody here could consider doing. For there's going to be some really big decisions that affect the local healthcare delivery system coming out of Washington, D.C. and Olympia in the coming months and years. I mean, big ones that will really affect how we are able to deliver care in this community. So I would really encourage everybody to be active in advocacy for the local delivery system. And I'm talking the local hospitals, the local physicians, local tribal clinics, local mental health services. Both in Olympia and Washington, D.C., there's proposals that could literally cut millions out of the local delivery system. And at Olympic Medical Center's website, we're going to update the information right after the election, but there's information on proposed legislation at both the federal and state level and how they would affect the local community. So you might want to go to that OMC's website, look at it, and you can email or call your local officials with how you feel public policy should be, because it will have big effects. And the other thing I just want to mention is we're really blessed in this community with two great free clinics, VMO and Dutchess Valley Health and Wellness Clinic. And I would really, I know there's a lot of supporters just looking in the audience and a lot of people, but I would really encourage everyone to support both financially and maybe volunteering at these free clinics, because and for those of us insured, we don't know how lonely and scary it is to be uninsured and what a bad outcome it can happen on your life. So I really encourage, because those free clinics need everything we can give them. So any support you can give would be greatly appreciated.
All right. I don't see a big line for questions. Oh, here it comes. Who would like to start? George will.
I could just tell you what the solution has been in the United Kingdom, where they have a national health program. They have an institution called NICE, which means the National Institute for Clinical Excellence. And they have the tough decision of deciding if a brand new drug for cancer, for example, comes along and costs X thousands of dollars a month and gives you 3 months or 4 months of long life, the cost-benefit analysis is done in a hard-headed way, and sometimes, unfortunately, they make the decision that it's better to use the funds in other ways, for preventive medicine, for example, and they'll deny the utilization of that. However, in Scotland, they don't do that. They're a little more liberal. In Wales, they don't do that. So it's an ongoing situation. Oregon State has come to grips to some extent with this terrible problem of rationing. And sooner or later, I think it's a very good question. We still need a lot of research on that.
Just a quick comment. You know, I would call this, if you're using evidence to make these decisions, this is, I would call this rationalizing, not rationing. You know, it's trying to use rational criteria for making these selections. But the thing I would add to this is defensive medicine is real. People do unnecessary tests because they think they have to protect themselves liability-wise. So we need to fix that part of the system too. We need to do liability reform to get down the rates of defensive medicine, because that's at least part of the unnecessary testing.
I would just say that I think the best place to make those decisions are between a physician and a patient. And what we really need to do as a society really have more discussions about end of life and palliative care earlier, because a lot of times we wait until people are in the ICU before we have any discussions about personal wishes. And I think we spend far too much at the end of people's lives when it's not very useful. I think physicians and patients would make very wise choices. Each person might make a different choice. I think the ultimate question is, what should society pay for and what should individuals pay for? And society is going to have to decide what they're willing to pay for, and then we're going to have to collectively tax ourselves to pay for it. But I think if you look at healthcare delivery systems like Clallam County, we're fairly efficient. We have half the hospital inpatient admission rate as places such as Florida. We do half as many MRIs and CTs. So I think if you have a system that's focused on the community, primary care, public health focused, and there's no financial incentives for doing more, I think physicians and the patient can make some really good decisions.
David, do you have anything to add in terms of single payer?
Well, I think any system has got to have some rules and guidelines based on evidence and cost effectiveness, so that, but there has to be room for appeal if a physician and a patient decide that they want to do something. There's got to be a room for appeal there, and I think any of the systems that we've talked about, you know, that's something that needs to be set up after we figure out how to finance the system.
All right.
Could it
Good
just-
question. Thank you. Sorry. Yes.
Very quickly, one of the kind of innovations has to do with software that the physicians presented with. I think the example has been used for an MRI for a specific indication, and the physician has to answer a series of questions and get a numerical score. And if it doesn't reach a level of appropriateness for doing that MRI today, they have to wait until they respond to an alternative type of intervention. And if it doesn't respond, then they'll try again and they'll get the green light. However, very often there's an option for the physician in that personal relationship to overrule that decision. So there are ways to use evidence-based medicine to address that question in a logical way.
There's a lot of disagreement about what the cost impact is, although probably the most liberal estimates of it, it's about 2 to 3% of system cost, and that sounds small, but remember the denominator, the 2.6 trillion dollars, and tort reform comes in a lot of different forms. If people want to see a really innovative form, look at what the state of Michigan is doing. That isn't about capping awards and restricting people's access to the courts, It's much more, it starts with an apology and an evaluation of, has a mistake been made, and an offer of settlement. And the part about tort reform that is really expensive is going to court. And the part that drives physicians to believe that they're going to be judged unfairly in a court by a jury on emotional terms, and so they get a lot of extra tests to try to, prepare their defense for a court case. And you shouldn't have to think about that every time you're treating a sick patient.
David? David?
I just had a couple of things to say. In Canada, the malpractice costs per physician are extremely low compared to the United States. And second is, part of the malpractice award goes to health care for that person the rest of their lives. So in the United States, it's within our industry-dominated system, so the costs are going to be much, much higher. If we had a single-payer system, the cost would be much lower, and it wouldn't be part of a malpractice award.
I just want to say, I think tort reform is key if we're going to reform our delivery system. There is no way we could move to accountable care organizations, in my mind, without significant tort reform. I do agree with you, physicians really have a difficult time practicing. When you just turn on the TV and you see lawyers looking for patients so they can sue, I don't think physicians and the entire delivery system can move from a fee-for-service system to a system based on value without huge tort reform. And it's got to be done if we're going to change our system in a meaningful way.
Well, this is one of the problems that we see with the Affordable Care Act, in that it continues the dominance of the private health insurance industry and the medical and industrial complex as the underpinning strongest part of our healthcare non-system. So we feel like it probably set us back a few years, because people are going to say, well, let's just give this a chance and see what happens. We think that's a very bad idea, although there are a number of good things within the Affordable Care Act, because it's going to leave at least 27 million people uninsured when it's fully implemented. And we know from our past research that that's going to mean at least 26,000 people are going to die every year simply because they don't have health insurance. People who do have health insurance are going to have underinsurance, which is the new norm. In Massachusetts, their plan there has not been shown to reduce medical bankruptcy. And the same thing's going to happen under the Affordable Care Act. It doesn't control costs. So how are we going to get to where we need to be? I think realistically, the first thing we have to do is get money out of politics with campaign finance reform laws. And we've got to get a social justice movement going with healthcare as a human right, such as social justice movements of our whole history in this country that's been the way to make the powerful listen to us, by getting the grassroots out there, maybe in the streets if necessary.
I just want to add that the good news is that we managed to pass a law giving us Medicare in 1965. And so let's not forget that. It can be done. So I'm optimistic in the long run that we can make progress.
Any other comments?
I just want to say the other thing that really amazes me, not only the power of the insurance companies, but the power of big pharmacies. It is amazing what OMC has to pay for our medications, which are going up 8 to 10% a year. And I think some logical laws, one proposal that passed the House but failed the Senate was to allow us to buy our pharmacies at the same price, because we're a governmental entity, the same prices as the VA. And that would have saved millions of dollars, but it can't get through the Senate. But what I would do, one thing I've always thought we should do with our delivery system, it's so complex and there's so many payers, but if we took Medicaid and we moved all the Medicaid into Medicare, just made it one program, government programs for Olympic Medical Center are 75% of our patients. And I would personally love to see Medicaid roll into Medicare, because Medicaid reimbursement is so below cost, especially at the physician level. I think that would start having fewer payers. The other thing that's happening is hospitals and big systems are getting into the health insurance business. So there's going to be some different competition for insurance companies in the coming decade.
No, I would just add this notion that someone quoted Max Baucus as single payers off the table. That's only true if we let it. The argument that single payer is the successful path of every other major developed nation in terms of funding healthcare is just it's an inescapable argument, because these countries are also our global competitors, and they're all doing this at a much lower cost than we're doing it, and that's going to catch up with it. So I think it's inevitable that we will have a single payer system in this country. It's really just a question of when that happens, and that will be influenced by people raising their voices and constantly saying there's a better way to do this than what we're doing now. Well, you could give a whole talk, we could spend the whole night describing how we got to where we are now. I would go back to this notion that systems are perfectly designed to achieve the results they actually get. The result we have gotten is how our system is designed, even though it wasn't intentionally designed. If we want to change the epidemic of obesity, we have to change the way we market food and the preferences for food and how we educate kids about food. It's a complex problem, but it's solvable. I think the reason that these sort of health reform visionaries are looking so much at the activated patient is that changing the measure of value in the system from the providers and the purchasers and the insurers of care to the consumers of the care is a radical notion. Because we as patients, we don't want the most expensive, most complex, most disempowering care that we can get. We want stuff that works, and we want stuff that's convenient and accessible and feels good and makes us feel cared for. The values that people have as patients, and eventually we will all be patients of this system, if we haven't been already, those are the right values to decide whether something's going in the right direction or not. So I think that's why people are putting their hope in it. And the information technology is what's driving it. There are now systems where you have complete access to your health record on your smartphone, and another touch of a button gives you all this understandable information about the problems you have and what you can do about them. And this is just starting. We have extraordinary capabilities in that area that we're not using yet.
Say that information technology is also one of the main factors for the obesity.
Well, you're charitable to call television an information source.
I'm an underinsured small business person in SWIM. And you mentioned Vermont early on, and I was wondering, and all this is addressed to all of you, are there any steps we can take as citizens to start moving the state of Washington toward a model like it's happening in Vermont right now?
One hypothesis for the future would be to work together with like-minded regional states, and they would certainly include the state of Oregon, which is ahead of us right now. For example, the notion of healthcare as a human right. And they have something called mad as hell doctors down there. And also the state of California, which on 2 occasions they passed a single payer law, and it was vetoed by Governor Schwarzenegger. And they came close recently in passing a law. So that's a huge population. And at the upcoming meeting in San Francisco, we're going to meet a representative of the group in Hawaii. And Hawaii is quite advanced, not as advanced as Vermont. So there's a possibility of a consortium of states that has a large enough pool to make it work, because we have the option in 2017 to opt out of the system and try another experiment. And I like very much that part of the Affordable Care Act. I like to see experiments that work, model systems. So that's one possible answer to where we can go and how we can go. David?
Well, in Vermont, they have a commitment from their legislator to move towards a single payer system in 2017 when they can get a waiver. The Affordable Care Act allows waivers at that point. They're trying to move it up to 2014. But right now they have to work within the Affordable Care Act on their exchange. So the people who did this grassroots organizing enough to get the legislator to commit first to a feasibility financial study that William Schall from Harvard looked at their state and said, here's 3 possible programs, and they recommended a variant of a single payer, and that was passed by the legislature and supported by the governor, and incidentally, both candidates for governor that year ran on the single payer. We're going to get their program. It's called Green Mountain Care. So there was a tremendous amount of grassroots work before they got to where they are, and hopefully they're on the road for that. In Washington State, we've had a single payer bill introduced, I think for the last 6 years or so. I know 3 years ago we had hearings in both the House and Senate. It's called the Washington Health Security Trust, and if you go to Healthcare for All Washington's website, you can take a look at that bill. Some members of that board just met with Eileen Cody this morning to find out if there's any possibility for healthcare reform in the coming legislative session. She said basically no, they're going to be working on the exchange and some other issues so that a state single payer program for Washington is not in the works, but we can be laying the groundwork with educational sessions like this, and talk to your neighbors and friends and churches and whatever, and just say, single payer is evidence-based. It's every other industrialized country uses it. They spend half as much and have much better results.
Any other?
I'd just like to say thank you all so very much.
Okay, quick question, because I have about 1 minute.
Okay, well, this is quick enough. Do you see any possibility of the exchanges moving us toward a single payer? Could there be an exchange set up that included the subsidized programs that already exist, like Medicaid, Medicare, and the uninsured, in a public option?
I need brief answers.
I would just say I think the exchange will help. One of the things that Representative Steve Theringer is working on, there's about a dozen state programs, and they're consolidating those down, hopefully to 2 or 3. And I think it'll be much simpler for individuals to go on the exchange and get a product. But it's certainly a start.
Any other brief answers?
But those are only private insurance plans that are going to be available on the exchange. They specifically took the basic health plan, which is a kind of Washington state public plan, if you will, out of that, so it's not going to be available.
Well, keep in mind the mantra of Medicare for all, from conception to death. We want good prenatal care, to Medicare for everybody.
I have a few remarks to make, but first, please join me in thanking our panelists. We have recorded you because we hope to bring this to others in the community. thank our timers. Nice job. Well, we are done, but before you leave, you must meet the committee that's been responsible for the forums. And I'm going to say their names and ask them to stand when I do that. Besides me, there is Sarah Johnson, our chair, who arranges all the printing, posters, and leak support, along with always being inspirational. Sharon Lee, although she deserves it, we'll wait till the end and applaud us all. Sharon Lee, who amazingly worked very hard on our forums, along with chairing the committee for election forums at the same time. She also donated the donation jar. Susan Mullen is responsible for the design and processing of posters and printed programs and any perfection we may have achieved. Dory Rear has the role of bringing us back to earth when we are getting too full of ourselves. Tommy Schwentz has done a great deal of work in coordinating the facility and technical support and preventing the worst things that could happen. Mary Wegman has contributed immeasurably to the program concept and content. She is simply a great and compassionate thinker. Jennifer Taylor, our Port Townsend connection. Where are you, Jennifer? Please take this. Mostly, we thank you for being here, and besides reminding you that we have a donation jar that you will see on your way out, we want to encourage your continued involvement in healthcare in America. Because of these forums, I learned about someone in our community who has done significant study on his own about the healthcare costs, especially in relation to his concern about the deficit that threatens to cripple this country. He has read the IOM reports on his own. Wasn't paid to do it. And he's right there. Paul, wave your hand, please. And Paul has written several papers, and he'll be happy to give you his email if you are interested in seeing his papers. The reason I bring Paul up is because he lamented in one of his emails that there was so much we know, and yet presidents and Congresses have not acted on this information. Now, I suspect that Paul, in fact, I know that Paul and I might not agree on some aspects of healthcare reform, but we can talk about it. And in this, we do agree. That's why we need to make our voices heard. You heard everyone here tonight say, we have got to be active participants in this, and we have got to tell our elected leaders that we expect them to do their work. Please stay involved and start by marking your calendars to attend the community discussion sponsored by the Health Department and the League of Women Voters on November 14th in Mayer Hall on this campus. It's your opportunity to have a voice in the future of your community. Thank you. Good evening.